Good morning. It's my pleasure today to speak about one of the important issues in nephrology, which is chronic kidney disease progression, how to prevent. I think if we succeed as nephrologists to prevent chronic kidney disease or to prevent the progression of chronic kidney disease, or at least to delay the progression, this is a great achievement that we can do. Always I'm happy to deliver this presentation, and this was the last presentation on November last year. But today I'm going to update the information regarding the issue of prevention of progression of chronic kidney disease. And I take the opportunity because I was invited by Professor Tariq El-Baz to deliver a presentation entitled Prevention of Chronic Kidney Disease Progression. Are we doing enough to review all the recent updated aspects of this issue? And this is the first part among the three presentations regarding this issue. So I divide the full presentation of retarding progression into three presentations. In this part, I'll start with introduction, and then why chronic kidney disease is an important situation, what are the risk factors and contributing factors for chronic kidney disease and its progression. Then I discuss the issue of old age and chronic kidney disease, gender and chronic kidney disease, hypertension and chronic kidney disease, and diabetes and chronic kidney disease. So all these are the corners of this presentation. Let us start with some questions. So dear Dr. Ahmed, I want just to know from you, for each statement, is it true or false? Albumin creatinine ratio of 40 milligram per millimole creatinine is considered A3. True or false?
True.
Old age is associated with inflammation and increased oxidative damage.
True.
Chronic kidney disease progression is more frequent in women in comparison to men.
False.
Systolic blood pressure in stage 2 hypertension is defined by systolic blood pressure equal or exceeding 160 millimeter mercury.
True.
Blood pressure threshold for pharmacological therapy is 130/80.
False.
Use of ARBs is superior to ACE inhibitors.
False.
Intensive blood pressure is protective against chronic kidney disease. By intensive, I mean to reach systolic blood pressure less than 120 millimeter mercury.
False.
ACE angiotensin converting enzyme 2 inhibition retards the progression of the kidney disease.
True.
Sodium glucose cotransporter 2 inhibitors are natriuretic and uricosuric drugs.
True.
So to start with, so I go through the presentation, and at the end we discuss the answer of these questions together. So to define chronic kidney disease is defined as reduced GFR less than 60 ml per minute for a period more than 3 months. This is one definition. And the other definition, even if the GFR, estimated GFR, is above 60, but there are parameters of kidney damage like persistent albuminuria, persistent proteinuria, hematuria, or electrolyte disturbance, or radiological evidence, or even structural damage as evidenced by renal biopsy, referring to chronic kidney disease. So chronic kidney disease is persistent of low GFR or kidney damage parameters for more than 3 months. And this is a smart slide, and this is one of the master slides. Always we use it for definition of chronic kidney disease. If you look here, this is the estimated GFR. Estimate means calculated by equation. And here, estimated GFR either above 90, 60 to 90, 45 to 59, 30 to 44. As you see, this is the stratification of estimated GFR. This is here, if estimated GFR is below 60, this is chronic kidney disease. and it is persistent for more than 3 months, irrespective to the degree of albuminuria. And if estimated GFR is between 45 to 59, this is stage 3A. 30 to 44, it is 3B. 15 to 29, it is stage 4. Below 15, it is stage 5. If estimated GFR is above 60 and no A2 or A3, this means that the patient has A1. A1 means albuminuria, excretion in the range of less than 30 milligram albumin per gram creatinine or less than 3 milligram per millimole creatinine. If the patient in this corner, this is a green corner, this means that there is no chronic kidney disease. So in this corner, the green, no chronic kidney disease. But if the estimated GFR is 90 or above, and there is A2 or A3, the albuminuria in this range, 30 to 300 milligram per gram, or 3 to 30, or above 300 milligram, or nephrotic syndrome, this is A3. The patient, even if estimated GFR is above 90, this is a stage 1 chronic kidney disease. And if in these two corners, and estimated GFR between 60 to 90, it is stage 2 chronic kidney disease. This means that we should have either persistent low GFR or presence of parameters of kidney damage, as I said before. Another interesting point in this slide is the color. So color here, it means a lot. If you compare the yellow, orange, and red, the more the darkened the color, the more the risk for what? For progression of chronic kidney disease, for acute kidney injury, for cardiovascular disease, and for mortality. So this is a very smart slide. So the definition of progression is progression of chronic kidney disease from this stage into these stages. So, and the chronic kidney disease by its default and its nature is progressive disease. But if we succeed to slow the pace of progression, this is an achievement. And this year, this is the atlas elaborated by International Society of Nephrology, including 187 pages, including a lot of data about chronic kidney disease and risk factors and epidemiological data from the world. So I recommend all nephrologists to just look at the data within this atlas. And this atlas shows the estimated global prevalence of chronic kidney disease in these ranges among different countries. So you can look at the here between 8% to more than 12%, but we should be cautious about the statistics. And I'll explain this caution just in a minute. Here, this is the distribution, and I trust this slide. Why I am trusting this slide? Because the number of patients who are treated with dialysis or transplantation are truly recorded. So this is a prevalence of treated end-stage kidney disease, either by dialysis or transplantation per million population. So you can look at the color map. Here, the very dark colored area means that the treatment for dialysis and transplantation exceed 100 per million, 1,000. This is 1,000 per million. And the other color here in Egypt, for example, Egypt is in this range from 500 to 1,000 per million population treated by dialysis or transplantation. So you can look at the map and just know the prevalence of treatment of end-stage kidney disease per country. Let us go to this. This is, again, according to the United States Renal Data System this year, that was released this month, showing the prevalence of different categories in chronic kidney disease. Here, this area of Greenland, it is approaching 80%. This means that we should deal with the statistics by some caution, because the real chronic kidney disease are within this range. So this is the real prevalence of chronic kidney disease. And here, if you are in the green corner, this is a flow risk for progression and for everything, for mortality, for cardiovascular, for acute kidney injury. And in the yellow one, it is moderate high risk. In this line, high risk. And if it is dark red, it is very high risk. Okay? I think the number can tell a lot. So why chronic kidney disease is an important disease? Because chronic kidney disease is associated with high risk of this is the percentage of the prevalence of the cardiovascular disease. Here, the blue color refer to the patients with chronic kidney disease. So chronic kidney disease is associated with frequent prevalence of any cardiovascular disease, coronary artery disease, acute myocardial infarction, heart failure, valvular heart disease, transient ischemic attack, peripheral arterial disease, atrial fibrillation, and thrombosis. So this means the presence of chronic kidney disease is bad news and associated with high rate of cardiovascular problem. And this is catastrophic because CKD is associated with high mortality. So this is the CKD curve, and here you can see the difference here. Even it can reach in some time to fourfold mortality in comparison to the absence of chronic kidney disease. So chronic kidney disease is associated with high cardiovascular problems and diseases and high mortality. And this is regarding the effect of different variables on the mortality. Here, it is axiomatic to know the older the age, the higher the percentage of mortality. So, and here, if you compare CKD to no CKD, you can find a great difference in mortality. So, the presence of CKD is bad news associated with higher mortality, irrespective to the demographic criteria that the patient have. And if there is diabetes and chronic and cardiovascular disease added to the chronic kidney disease, this increases mortality so much. So CKD is bad news associated with high cardiovascular disease, high risk of mortality, and if there are many comorbidities, the risk of mortality increases more and more. Regarding contributing factors, I think this is one of the very interesting reviews discussing the issue of chronic kidney disease. And this is one of the figures within this review showing that the risks are always there since the early life. So maternal malnutrition and disease can affect even eclampsia. Environmental risk factors and exposure to toxins, drugs, herbal remedies, infections, all these can lead to chronic kidney disease. Nephrotoxic drug, and here I want to announce and to raise the attention of all nephrologists to avoid nephrotoxic drug as we can. And even we should search for the drugs that we can deprescribe, like proton pump inhibitors, because we are abusing this class of drugs. Congenital anomalies of urinary tract like Alport syndrome, polycystic kidney, etc. Or severe genetic defect, moderate genetic defect, mild genetic defect, type 1 diabetes, autoimmune glomerulonephritis and interstitial nephritis, obesity and type 2 diabetes, physiological aging. Per se, aging is a risk, as I'll mention in a minute, atherosclerosis and monoclonal gangrenosis. So all these are contributing factors, and you can classify them into environmental, genetic, and systemic disorders that can lead to the chronic kidney disease starting from early life in utero up to the old age. And this table summarizes all risk factors for chronic kidney disease, including monogenic kidney disease, for example, autosomal dominant polycystic kidney disease, polycytopathies causing steroid-resistant nephrotic syndrome, Fabry disease, Alport syndrome, and complement related disorders such as atypical hemolytic uremic syndrome, congenital abnormalities like the reflux, physical reflux, type 1 and type 2 diabetes, poorly controlled arterial hypertension, obesity, prolonged exposure to nephrotoxins like treatment for cancer, non-steroidal, antimicrobial, contaminated herbal remedies, and the majority of herbal remedies are adulterated with many drugs like non-steroidal diuretics. So I am myself totally against the use of herbal remedies. And do you like them, Dr. Ahmed? Herbal remedies?
So, I think we recently encountered a case of acute kidney injury proved after herbal remedies intake. We didn't know actually the nature of what happened. So I'm not recommending it at all.
So to recommend any herbal remedies, we should have randomized control trial confirming that. And when you even go to the scanty randomized control trial done on herbal remedies, you'll find you should bring this herbal remedies from certain place, and it's not real in real practice. And the majority of herbal remedies are adulterated by toxic drugs. Climate, it is important to avoid excessive heat exposure and hydration. The infections and the chronic inflammation, malignancies, episodes of acute kidney injury, and I think it will be discussed later. Low nephron endowment, like low birth weight. Low birth weight is considered nowadays a risk factor for progression of kidney, and there are some centers all over the world consider low birth weight as contraindication for live kidney donation. So we should put all this in our mind, and obstructive uropathy. All the factors that carry this signal, this star, are factors related to progression of chronic kidney disease. So you can fix the slide and look at them. Let us go to discuss aging and old age. This is the United States Renal Data System showing the CKD in respect to the age. Here you can see the older the age, the higher the percentage and the prevalence of chronic kidney disease, all through the different decades. So aging is associated with chronic kidney disease. Either we use the estimated GFR below 60 as cutoff point, and I'll discuss it in a minute, or using albumin creatinine ratio exceeding 30 milligram per gram creatinine. So again, chronic kidney disease is common and prevalent in elderly. Here I want to ask you a question. Is it fair to use 60 ml per minute as cutoff point for defining chronic kidney disease in elderly? What's your opinion?
My opinion is not fair at all, because we know that there is a progressive loss of nephron over years and years. So I believe that we have to look for another equations to truly calculate the GFR in patients more than 60 at least.
Let me just here to remember the quotation from authors, and among these authors was the Professor Richard Glassow, who mentioned that if we say for persons who are aged 80 or 70, that 60 milligrams is the cutoff point, the majority of them will be chronic kidney disease. And it seems it is not rational to use estimated GFR less than 60 for this age. And it's better to use lower cutoff point, like 45 ml per minute. Because if you have an aged person with estimated GFR less than 60 and above 45, and there is no parameters of kidney damage, proteinuria, I think this person cannot be dealt as chronic kidney disease. But up to this moment, the definition of chronic kidney disease was not changed. It seemed that 60 ml per minute is an overestimating the problem in elderly and underestimating the problem in younger person. So we need to reclassify. This is a very interesting study done between, as you see here, Mayo and the Cleveland Clinic, and the study included evaluation of the biopsies, pre-implantation biopsies of live kidney donor. And the issue here, the substantial loss of nephrons in healthy human kidney with aging. If you look here, this is the age category of the donors, and the white bar reflects normal glomeruli, and the dark segment reflects sclerotic glomeruli. Here in young age, there is the majority of glomeruli are healthy, no global sclerosis. By aging here, the number of healthy glomeruli are reduced, the glomeruli numbers are reduced, and the number or the percentage of sclerosed glomeruli increases. So this is the effect of age with subsequent reduction of GFR. And there is a nice equation, which is the expected sclerosed glomeruli per age equals age divided by 2 minus 10%. If your age is 20 years, 20 divided by 2 equals 10. 10 minus 10 equals 0. This means if you do biopsy for a 20-year-old person, you'll find no sclerosed glomeruli. And if the same person lives longer until the age of 100 without any comorbidity, because he is 100-year person, 100 divided by 2 equal 50 minus 10 equal 40%. This means that approximate 50% of his kidneys will be lost. So aging is a process. And this is a very interesting point also. It's not only the nephron and the GFR, but the reserve within the kidney is diminished by aging. How to test the kidney reserve, Dr. Ahmed? Testing kidney reserve is either by stressing the kidney by infusing amino acid, and this was a study done here in the center for the donor. So measuring creatine clearance and giving the person's amino acid infusion and repeating creatine clearance, you can subtract the clearance before and after. This is the reserve within the nephron. And we can measure it without infusion by just exposing the person to heavy protein diet, like giving egg white, and measuring clearance before and after. And by this way, we can calculate the reserve. The reserve is diminished by aging. And if we look at the cellular and the physiological pathways, you can find all these factors are reduced. Vascular density and regulation, antioxidant capacity, telomere length, and it is important, anti-aging. The longer the telomere, the longer the survival, and vice versa. Reduction of autophagy, which is anti-aging system, BPAR level, close loop expression, anti-aging, oxygen delivery. So all these pathways are reduced by aging. And all these pathways, bad pathways, are increased. Angiotensin II sensitivity, inflammation. So the aging is the matter of inflammation, pericyte activation and fibrosis, WNT signaling pathway, FGF23 expression, and senescence pathway, and oxidative stress and oxidant damage. So why it is important to know all these academic and basic points? Because I am expecting in near future to have drugs targeting these molecules, so we can have anti-senolytic agents in the future. And this slide summarizes the panoramic view that the age-related signals include all these pro-fibrotic signals, vascular response, improper vascular response, a lot of inflammation, oxidative damage. So all the cell senescence parameters, all these are pathophysiological and structural, as I mentioned before. And these abnormalities can be translated into structural and functional changes. And this slide shows all these points in one figure. So we have, by aging, microscopically changes. If you can hear, this is the effect of renal aging. So there is glomerulosclerosis, interstitial fibrosis, pericapsular fibrosis, glomerular basement membrane thickening, arteriosclerosis, and tubular atrophy. All these are chronic changes within all the kidney structure. Okay? And macroscopically, this will be translated into reduction of the mass by 20 to 25% between age 30 and 80, reduction of the kidney weight 10% per decade, reduction of kidney length half centimeter per decade, above 40, and reduction of the parenchyma by 10% per decade. So this is the fingerprint of aging on the kidney, with consequent clinical changes and functional changes. Clinical including progression of new chronic kidney disease, alteration of the survival, functional renal reserve, susceptibility to acute kidney injury, and functionally, reduction of GFR, and more importantly, affection of the smart function of the tubules. So there is problem in dealing with electrolytes, with sodium conservation. So elderly persons are more susceptible to dehydration. So this is, all these points should be put in mind to be careful about handling the elderly persons. And it seems that the effect of environment is there. So there is a lot of epigenetics with aging. Epigenetic means the affection of the gene by environment. So all these features of epigenetic landscape that affect renal function, including post-translation histone modification, chromatin remodeling, DNA methylation changes, RNA methylation changes, and non-coding RNA changes. All these are increasing with age, with subsequent acceleration of the process. So why I am interested by this sector? Because you can find drugs handling these issues. Again, all this is a summary for the effect on the epigenetics, and as you see, telomere attrition, deficient response to DNA damage, metabolic shift, all these can lead to all the kidney or chronic kidney disease. And this is regarding the epithelial cell. Here you'll find the autophagy system is really affected. So a lot of pathogenic mechanisms are there on the cellular and the molecular points that deserve more and more academic research trying to modulate the effect of old age on the kidney. And I'm happy because currently we have the guidelines dedicated for chronic kidney disease in elderly. And the most important points in elderly is to deal with them sensitively, monitoring kidney function, avoiding nephrotoxic drugs, using suitable formula. And I think from the guidelines, if you are suspicious, the best formula in elderly is a combined creatinine and cystatin C formula. And if the drug can be monitored by level, it is better to use drug level. Regarding gender, so this is regarding aging. I think we should think of, up to this moment, we should deal sensitively, cautiously with elderly person, avoiding all others. Here I want to just add a statement. That when we study risk factors, it's better to classify them into modifiable and non-modifiable risk factor. If I ask you, is aging a modifiable or non-modifiable?
No, it's not.
It is not modifiable. Why it's important to know all these points regarding non-modifiable risk factor? To be cautious. So this patient will be more susceptible to the modifiable risk factors. So I should be careful in dealing with elderly person. Regarding gender, this is the United States Renal Data System. If you look here, the prevalence of all CKD here for women or for female, it seems that it is the same or higher than the CKD in men. So the frequency is the same or higher in women. But the most important is, look here, these are different countries regarding the incidence of end-stage kidney disease. If you look for male and female, you will find the end-stage kidney disease is more common in females. So why? It seems that the progression of chronic kidney disease is more fast in women. Is it because female sex hormone? We don't know. Is it because the bad male sex hormone in men? We don't know. But there is a nice case report that was published since a year about the use of testosterone and its impact on the kidney perfusion and the kidney function by angiography, by CT angiography and GFR. And the case was hypogonadism treated by testosterone. And they found that testosterone can affect the kidney badly. So it seems that testosterone is bad. Regarding hypertension, it is one of the most practical sector in this presentation. Please be attentive. So this is the prevalence of hypertension. Here, this is the most dark is hypertension exceeds 30%. So in these areas of the world, blood hypertension exceeding 30%. In Egypt, here, Egypt is between 25 to 30%. So this is the prevalence of hypertension according to the ISN map and atlas. And this is very interesting data. Look, please, carefully. Here, this is the old CKD. The majority of patients here, according this is, but fortunately, currently there is increasing awareness of hypertension. So it seems there's partial success in managing hypertension, because in the past, the majority of patients were unaware by hypertension. And here, this is a problem. Aware and not treated, and aware treated uncontrolled. So it seems that we are still doing not. We still need to do more and more control of blood pressure, because this is very terrible data. The patients are aware of hypertension and treated with inadequate treatment, approaching 40%. So this is a point that needs some action. This month, the recent guidelines of American Cardiology Association, American Heart Association, and other societies, the guidelines were released in the online issue of Hypertension journal. And if you look at the guidelines, you'll find here the green color means benefit exceeds harm. And if you go to the dark, here harm exceeds benefit, and here the benefit is more than the harm. Here the harm equal benefit. And this is the evidence, this is level A evidence, and this is randomized evidence, non-randomized up to the expert opinion and the low evidence data. And the most important, and from my mind, is the definition of hypertension is drastically changed in this version of guideline. Look here, it is very surprising. Normal blood pressure in adult is considered the blood pressure is less than 120, and diastolic is less than 80. Elevated blood pressure is considered if systole is between 120 to 129 millimeter mercury, and diastole is around 80 or less than 80. Hypertension is stage 1 is changing. It becomes between 130 to 139, and diastole between 80 to 89, which was not hypertension in the past. Yeah. And the stage 2 hypertension is just 140 and 90. So this is a change, major change in the definition. And this is regarding chronic kidney disease and treating hypertension. So it is level recommendation based on randomized studies. Adult with hypertension and chronic kidney disease should be treated to a blood pressure goal less than 130/80. In adults with hypertension and chronic kidney disease, ST3 or higher, or albuminuria in this range, the first, the treatment with ACE inhibitor is reasonable to slow the kidney disease progression. And it seems that the ACE inhibitor is superior to angiotensin receptor blocker. And angiotensin receptor blocker is better choice for those who are intolerating ACE inhibitors. An adult with hypertension, CKD stage 3, with albuminuria exceeding 300, treatment with ARB may be reasonable if an ACE inhibitor is not tolerated. Here I want to ask you just to raise your attention regarding the first line treatment. What is the first line treatment for hypertension in general, according to the guidelines? Calcium channel blocker, ACE inhibitors, angiotensin receptor blocker, and thiazides. Beta blocker is not within the first line drug, and just indicated when there is compelling indication like ischemic heart disease. So beta blocker is not considered a first line of treatment. And this is the algorithm. A blood pressure is within this range. The albuminuria is above 300. If yes, use ACE inhibitor. If no, use first line medication like calcium channel blockers. Okay, I think it is rational. But the target blood pressure, the threshold of blood pressure is reduced in comparison to the previous guidelines. And here again, the guidelines stated that combining ACE inhibitor and ARB is not indicated because it is harmful. This is the level A evidence for harm. So it is harmful to combine ACE inhibitor and ARB, or combining any of them with renin inhibitors. So this combination is not welcome. This is a very smart table. Why? Because the majority of indications for the treatment, pharmacological treatment of hypertension is just 130/80 in the majority of cases. And the goal is just to reduce blood pressure to less than 130/80. I think it is rational because they didn't put here less than 120. Because intensive blood pressure, and as I mentioned later, there is no solid evidence for this issue, and it may even be harmful in some situation. So the cutoff point in the majority of situations is 130/80. And this is again the same algorithm for, so if you are here in the normal blood pressure, just non-pharmacological treatments and following the proper lifestyle. And here you can follow this algorithm to know the best management of hypertension. And this is, as I mentioned, the first line includes thiazide, calcium channel blocker, ACE inhibitor, or angiotensin receptor blocker. But to use ACE inhibitor, if there is albuminuria or proteinuria, I think it is rational in this point. And this is the idea and opinion regarding the, commenting on the guidelines. And I like this statement. This was issued yesterday. The recent incongruity. Incongruity, what does it mean? Disparity or disconcordance between the different guidelines may jeopardize patients' trust in the healthcare system. As providers, the most valuable conclusion we can convey to our patients is that a guideline is never a substitute for clinical judgment. So this is why we should evaluate every patient separately. Regarding the issue of intensive blood pressure, is it important? Is it beneficial for chronic kidney disease? This is the study that was released on September regarding the effect of intensive blood pressure control on chronic kidney disease, including this number 1330 and 1316 patients, intensive and standard treatment. By intensive treatment, systolic blood pressure to be lower than 120. Here, if you look here, there is no significant difference in primary cardiovascular outcome, and no difference in all. There is significant reduction by adopting the intensive blood pressure control. It seems that there is beneficial effect on death. So intensive blood pressure is associated with reduction of all-cause deaths, but no difference in kidney outcome. So this study shows that there is no benefit for kidney disease progression by applying intensive blood pressure control. And this is a systematic review and meta-analysis showing the same. We should be cautious because there is no documented and no evidence base that the use of intensive blood pressure control will reduce chronic kidney disease progression. And to reach less than 120, you need to give more than one drug, and it is more costly. Regarding this study compares the chronic kidney disease progression regarding the style of blood pressure control. Here for intensive in comparison to standard. If you look here to the red corner here, the event per 100 person per year regarding the incidence CKD is 1.33 in the intensive treatment group. It is 0.37. So, and this is very statistically significant. So the incidence of chronic kidney disease increased by threefold with intensive blood pressure control. Even if there is cardiovascular benefit and reduction of mortality, because if you look here for all-cause mortality, it is 0.7 in comparison to 1%. So it seems that there is some cardiovascular advantage for intensive blood pressure control, leading to reduction of mortality. But if we think of chronic kidney disease progression, there may be increasing even in the incident CKD by applying the policy of intensive blood pressure control. Even if we are convinced by intensive blood pressure control, we should monitor the patient well and individualize our management. So again, intensive blood pressure is associated with lower cardiovascular, lower death, lower composite endpoint, but increasing the risk of chronic kidney disease. Another important point is the sleep time blood pressure. This is the statement that was said before, dipping and non-dipper. Non-dipper means that the asleep blood pressure is high, or there is no physiological decrease during night with the blood pressure. Again, this study shows that the higher sleep blood pressure is bad news and associated with chronic kidney disease. Regarding the issue of angiotensin converting enzyme 2, this is a different enzyme. So we have angiotensin converting enzyme, we have 1 and 2. The 1 is responsible about angiotensin 2, and this is harmful. This is why we need ACE inhibitor or angiotensin receptor blocker to stop its action. But angiotensin converting enzyme 2 shifted the metabolism of angiotensin and angiotensin pathway into angiotensin 1 to 7, which has anti-inflammatory. And it seems that angiotensin converting enzyme 2 is shedded in diabetic nephropathy, for example, in urine. So it seems that expression and activity levels of angiotensin converting enzyme 2 are altered in the kidney and urine from patients with diabetic nephropathy, and urinary angiotensin converting enzyme 2 may be reflective of its shedding from proximal tubule. And I think we are waiting studies in human that confirm and to find the way to stimulate, to activate angiotensin converting enzyme 2. So angiotensin converting enzyme 2 enzyme is beneficial. Is beneficial, and delivery and stimulation of angiotensin converting enzyme 2 or stimulation of angiotensin converting enzyme 2 alone are putative therapeutic approaches for treatment of kidney injury, at least in part by exerting beneficial effect on renal function and attenuating kidney inflammation and fibrosis. And again, in proximal convertible, there is the pathway of, and this is academic. We have here the angiotensin system working on the kidney. So this is the bad side. So it will lead to increasing intrarenal RAS system activation, increased sodium absorption, decreased pressure natriuresis, decreased circulating RAS activity, and decreased natriuretic response to dietary sodium, increased effective circulating volume and blood pressure. And if we block this pathway, it will lead to a reduction of intrarenal RAS, increasing pressure natriuresis, decreasing blood pressure. And this may be by the use of ATRAB. ATRAB means angiotensin 2 receptor associated protein. So the use of angiotensin 2 receptor associated protein is green. Green means beneficial. But in contrary to the ARAB one, it is harmful because it stimulates angiotensin 2 related action. And this is, it seems that the pathway and working on the proximal convertible needs a lot of research to find a venue for modulation. The last sector in this presentation is diabetes. Regarding diabetes, the map of the world, as elaborated by the ISN, shows the percentage of the prevalence of diabetes all over the world. Here, Egypt is within the very high prevalent countries, and it's bad news. Okay. This is the point that insulin resistance and chronic kidney disease are contributing to the same bad pathways. So you can find a lot of issues related to chronic kidney disease and insulin resistance are interacting together. So we have glucose dysregulation, uremic toxin, hypertension. So there seems that there is link between chronic kidney disease and insulin resistance. And this is a very interesting point, which is hyperfiltration. Hyperfiltration is present on type 1 diabetes in between 10 to 67%, and type 2 in between 6 to 73%. To show you the value of hyperfiltration, if you look here, if we look at this point, it is 120 milli per minute GFR. And if you go here, what is the GFR here? 120. But what happened to the kidney? It is loss of 50%.
But still the
So if we can work here in the area of hyperfiltration, and to reduce hyperfiltration, we can keep and preserve the nephron in the long term. And these are the factors why there is hyperfiltration, because there are many factors that can lead to afferent vasodilatation, like the vascular factor and tubular signals, inhibition of tubuloglomerular feedback, or factors causing a net increase in the arterial vasoconstriction of the efferent arteriole. So we should look at these factors. If we wanted to change hyperfiltration, we should ameliorate afferent dilatation and ameliorate efferent vasoconstriction. The concept of single nephron GFR, I am very interested by the issue of single nephron GFR, because you can find a person with GFR 80 milli per minute, and if you measure single nephron GFR, you'll find everything is nice. But if you measure for another person with hyperfiltration, you can find this person is keeping 80 milli per minute in the expense of hyperfiltrating the single nephron. So how do you know how to measure single nephron GFR? This is a method that was published in June this year. This is the renal biopsy and the CT. So by CT, we can measure the volumetry of the kidney, and by isotope clearance, we can measure the total clearance. So by measuring total clearance, and evaluating the nephron, the volumetry by CT, and doing kidney biopsy. Here we have the biopsy. As you see, all these are healthy glomeruli. So if we multiplied, if we calculate, if we know the total nephron mass by CT volumetry, and to be multiplied by the density of the normal glomeruli, what does it mean? The total volume is multiplied by number of healthy glomeruli divided by total number of glomeruli, healthy and sclerosed. This will give us the total nephron. And when we measure GFR by a STOBI scan, then we know the total GFR. You divide the total GFR by the total number of nephron, you can calculate the single nephron GFR. So it is very fantastic and sometimes explain a lot of issues. So if you look here, if there is glomerulosclerosis, the total number of nephron is reduced by 200,000 nephron, and it is significant reduction of the volume of the kidney. And here what happens? The single nephron GFR increased by 22 nanogram per minute, nanoliter per minute. This means that the kidney keep its function through hyperfiltrating the function nephron. So if we know this and we deal and handle this hyperfiltration on the nephron, on the single nephron basis, we can change the phase of hyperfiltration. Again, we should classify the patients according to their category and their trajectory and their progression. So we have, if we measure the GFR every year, and then if the slope is above 15 milli per minute per year, this is very fast progressor. If it's between 10 to 15, it is fast. Between 5 to 10, it is moderate. And it is less than 5 milli per minute per year, it is a slow progressive. So if if you are dealing with a person with a very fast reduction of the GFR, you can expect to have end-stage kidney disease for this person in 2 to 5 years. And if the patient is within slow, the end stage can occur after 20 to 45 years. So if we want to change the prognosis of diabetic kidney disease, it's better to know how to handle this trajectory, to change it from very fast into slow progression. And I think the secret of success in the early detection and diagnosis. So if we can deal earlier, we can change the red one, which is very fast, into a little bit slower progressive. Regarding pathology of diabetic kidney disease, diabetic nephropathy, I think the threshold for doing renal biopsy is currently reduced, because you can find diabetic nephropathy or non-diabetic kidney disease in a diabetic patient. And this article shows here, look here, Dr. Ahmed, the 5-year renal survival is drastically reduced in the presence of classic pathology of diabetic nephropathy. Yes. This is in comparison to non-diabetic renal disease in a diabetic patient or in combination, because here 5-year survival is reduced from approximately 100% in 5 years to 50%. And this is a very significant reduction in the kidney. And the presence of glomerulosclerosis is bad predictor for the renal failure and increased lower survival. And the most recent pathological article regarding diabetic kidney disease is this article showing segmental sclerosis and extracapillary hypercellularity. Here, this is the segmental sclerosis, and this is the extracapillary hypercellularity. The presence of these two lesions are associated with the progression, and here, as you see, this is the univariate model for others. It's twofold. So for segmental sclerosis, and the same for extracapillary hypercellularity. So it seems that the pathology will add a lot. This is a systematic review in the Cochrane reviewer showing that in these 14 studies, including 29,000 patients, that using the very low level of glycemic very low level of A1C is not superior. So it seems, but I have my opinion in this issue. If we are dealing with a patient with preserved GFR, this means we are in the early stages of chronic kidney disease. It's better to control glycemia meticulously, because reduction of the hyperglycemia in this scenario will protect the kidney in the long run, provided that we monitor glycemic state to avoid hypoglycemia. In contrary, if the patient has a stage 3B, 4, or 5, our goal is not to protect the kidney but to avoid hypoglycemia. This is a priority because these patients are more prone to hypoglycemia. So if we are in stage 1 and 2, yes, for A1C less than 7%. But above this level, above stage 3B or 4 or 5, I think 7%, as mentioned in KD guidelines since a couple of years, or even we can increase the level if there is any episode of hypoglycemia up to 8 or 8.5%. This is one of the classes of drugs, which is sodium glucose cotransporter 2 inhibitors. And as you see, all these are the landmark studies. So the EMBRIG outcome trial that was published in New England in 2015, and the kidney outcome was published in 2016, and the CANVAS canagliflozin, which was published this year in New England Journal of Medicine, and showing nephroprotection by the use of this class, because this class is natriuretic, glucuretic, and uricosuric, and a lot of actions that reduce inflammation. And this is declared. We are waiting other studies, Credence, DABA, CKD, all these studies, we are waiting further studies showing the benefit of this class. And this is the meta-analysis showing the uricosuric effect of sodium glucose cotransporter 2 inhibitor. So if we have hyperuricemic diabetic patient, I think this is an advantage for the use of this class. This is the most recent publication regarding the issue of sodium glucose cotransporter 2 inhibitors, which the use of canagliflozin to target either primary prevention or secondary prevention. And it seems that this class is effective against cardiovascular problems, especially in secondary prevention. What's meant by secondary prevention and primary prevention? If the patient has a history of cardiovascular problem and you are treating now diabetes by this class, this is secondary prevention. It seems this class, the drug is very effective in this point than in primary prevention. I already recorded all the issues and aspects of sodium glucose cotransporter since 5 months. The most important slide within this presentation is the karma of glucoresis. What's meant by karma? It is the ethics of using this class. What's meant by ethics? The physicians who are using this class should know the precautions and contraindication. So prohibit the use of sodium glucose cotransporter 2 therapy in moderate to severe chronic kidney disease, stage 3B or higher. This is because they are either inefficient in this environment because they need well-functioning kidney for glucuretic effect, or there may be side effects. They are not accepted for pregnant ladies or breastfeeding females, for the treatment of diabetic ketoacidosis, or the situations that may precipitate ketoacidosis like surgery, etc. So all these are problems. And observe caution for patients with risk of volume depletion, because they are glucuretic, natriuretic, so they may increase volume depletion leading to acute kidney injury or problems in these patients in combination with diuretics. So we shouldn't use them simultaneous with loop diuretics because this is bad. But we can use, from my opinion, for a patient with heart failure and diabetes, we can add, but we should be cautiously given this combination. History of recurrent UTI, because glucoresis increases infection. Patient with already elevated hematocrit, because this will lead to more and more hemoconcentration, and it is unapproved in other situations. So we should be careful. Even for patients with some cancer, like bladder cancer, dapagliflozin in this scenario is not welcome. So we should know when to use and how to use. If this class is used earlier in chronic kidney disease, we can take the benefit of their nephroprotective effect without jeopardizing the patient. Regarding glucagon-like peptide 1 agonist, this is the very interesting review showing the effects of this class either by using glucagon peptide 1 agonist or using DPP4 inhibitor, which keep the incretin. So all these are the pleiotropic effects of GLP-1 analogs or agonists. On the brain, reducing food intake, decreasing water intake, increasing neuroprotection, increasing neurogenesis. And this is why there is in Parkinsonism there is a study for the use of glucagon peptide 1 agonist for this patient for outside the diabetic state. So heart and vessels, increasing glucose utilization, increasing cardioprotection, increasing vasodilatation, decreasing fatty acid metabolism. On the kidney, increasing diuresis and natriuresis. On the immune system, decreasing inflammation. On skeletal muscle, increasing perfusion, increasing glucose uptake, increasing thermogenesis in adipose tissue, and increasing perfusion, increasing lipolysis and glucose uptake by white adipose tissue, decreasing steatosis, decreasing very low dense lipoprotein, decreasing glucose production by liver. And on gut, increasing growth, decreasing motility, and decreasing lipoprotein secretion. On pancreas, increase insulin secretion and biothesis, increase somatostatin secretion, increase beta cell proliferation, decrease glucagon secretion, and decrease beta cell apoptosis. So all these are pleiotropic effects of this class. And this is this table. You can fix this table just to look at the short-acting GLP-1 analog and long-acting ones, and to see their modification with the chronic kidney disease. And this is for DPP4 inhibitors, all the different names with their modification. And this is a concept. The use of glucagon-like peptide 1 agonist leads to reduction of hyperfiltration. By here, they inhibit all these pathways, leading to efferent vasoconstriction and releasing efferent vasoconstriction. So it reduces, at the end, it reduces hyperfiltration. So it seems that glucagon-like peptide 1 agonist, DPP4 inhibitors, and sodium glucose cotransporter 2 inhibitors are, which are new classes, relatively new classes added to the armamentarium of type 2 diabetes. When given to the appropriate patient, they exert beneficial effects on the kidney. And this is again other actions in dyslipidemia, inflammation, and fibrosis. You just fix them and read all the details. And this is the human study about liraglutide and renal outcome. So liraglutide is added to the armamentarium of treatment, and you can see here there is significant reduction of composite renal outcome. And if you look at the curve in comparison to the placebo, adding liraglutide is associated with significant reduction of urine albumin creatinine ratio. So this is another point. Regarding blood pressure in diabetes, it is very interesting to know that for adults with diabetes and hypertension, antihypertensive drug treatment should be initiated at a blood pressure 130/80 or higher, reaching a goal of 130/80. And in adults with diabetes and hypertension, all first-line classes of antihypertensive agents, diuretics, ACE inhibitor, ARBs, and calcium channel blocker are useful and effective. Here, as you see, beta blocker is not within the first class of antihypertension. In adults with diabetes and hypertension, ACE inhibitors or ARBs may be considered in the presence of albuminuria, and it is rational. And this is a concept. If you look here, if this is diabetes and you want to change, which is the best here? This is the glomerular filtration rate, which is the most preserved curve. The green one, here, green one, is associated with hyperglycemia control using RAS blockade and sodium glucose cotransporter 2 inhibitor. Again and again, we can use this class to reduce hyperfiltration so long as we can use them safely in the early stages. But in established chronic kidney disease, it's better not to use them. Let us go back to the questions and discuss them one by one. So albumin creatinine ratio of 40 milligram per millimole is E3. It is right, and you said it is true. It's true because here the message is we should be careful about the milligram per millimole or milligram per gram. Okay? So 40 milligram per millimole is more than 300 milligram per gram. So it is A3. All the agents associated with inflammation, this is what I mentioned, and increased oxidative damage. CKD progression is more in women, it's false.
Yeah.
Why false? Because the data is in different countries showing that the prevalence of end-stage kidney disease is more common in men in comparison to females. Despite the frequency may be the same of chronic kidney disease or higher in female, but the progression toward end-stage kidney disease is less in men. Systolic blood pressure in stage 2 is not 160 according to the current guideline, it's 140. And this is a drastic change in the definition. Blood pressure threshold for pharmacological treatment is 130 over 80. It was 140 over 90, but it's reduced. And I'm convinced by this target because this is the threshold, and just to reduce below the threshold, it's 130 over 80. Use of ARB is superior to ACE inhibitor. It is wrong because it is only right if the patient is intolerating ACE inhibitor. Intensive blood pressure is protective against chronic kidney disease. It is wrong because, as we stated, that the incidence of chronic kidney disease is higher with intensive blood pressure control. ACE type 2 inhibition retard the progression of kidney disease is wrong because stimulation of angiotensin converting enzyme type 2 is beneficial. This enzyme is beneficial. So to inhibit it, it is bad. So it is to retard the progression to stimulate angiotensin converting enzyme subtype 2. Yes, sodium glucose cotransporter 2 inhibitors are natriuretic and uricosuric drugs. In the second part, in the next week, you will find I'm going to discuss the sector of acute kidney injury and its link to chronic kidney disease, obesity and nutritional aspects and chronic kidney disease, blood-kidney axis, physical inactivity and its relation to chronic kidney disease, smoking, hyperuricemia, and sleep disorder and chronic kidney disease. So, and everything will be moved to the YouTube. And thank you for attention. And I'll be happy if you have any question.